What prompts a clinician who previously removed 100% of implants affected by periimplantitis to transition towards a strategy of treating the periimplant tissues? Find out the answer in this brief video. While modern implant dentistry shows a high success rate overall, the increasing number of implant procedures correlates with a rise in periimplantitis cases. Periimplantitis, a challenging disease to manage, is primarily triggered by bacterial biofilm accumulation on implant surface, leading to inflammation and bone loss. In the following 5 minutes, Dr. Giovanni Salvi from Switzerland will shed light on the periimplant diseases, including its prevalence and progression as part of the Straumann Smart Regenerative Educational Program.
How big is the problem? So if we talk about peri-implant diseases, we should not forget to mention the prevalence of those diseases. And in this systematic review by Derks and Tomasi, we can take two important percentages to give also our patients an idea of how prevalent such a disease is. Those are two figures, 43% for mucositis and 22% for peri-implantitis, that show to us that such diseases are not very or extremely frequent, but they are also, on the other side, not negligible. If we look, for example, at peri-implantitis prevalence, roughly 20% of patients, or in other words, 1 out of 5 patients is at risk to develop peri-implantitis. And just to illustrate this problem, I would like to start by showing to you a case with untreated peri-implantitis over the course of 4 years. The implant was placed in 2006 and restored with a single unit crown, but the patient did not receive any maintenance and any therapy when problems were discovered. And problems were discovered by means of X-rays showing a gradual continuous loss of peri-implant bone, 2007, more accentuated 2009, and even more pronounced in 2010. So as you can see from these 4 X-rays, untreated peri-implantitis shows a rapid progression, and we cannot just watch and see such an implant losing bone without any intervention. So this is what you see on the slide, the consensus report of 4 groups of peri-implant diseases and conditions defined at that time. But of course, if the patient stops cleaning teeth and implants, and you will see that in this case, tooth number 22, the upper left lateral incisor, is a crown supported by an implant in a patient that lacks oral hygiene. So as you can see on these pictures, the bacterial deposits have not only caused inflammation of the gingiva, but also inflammation of the mucosa around this implant. It's a bone level type implant. There is no bone loss, so it's an initial stage called peri-implant mucositis. And this was also defined at the World Workshop 2017 as an inflammatory lesion of the soft tissues surrounding a osseointegrated implant, but in the absence of loss of supporting bone. As you can see on the left, there is a profuse bleeding after probing, and on the right side there is even suppuration around this implant. And the main clinical characteristic of this disease is bleeding on gentle probing. And then the final step of the disease process that was defined at this workshop is the definition of peri-implantitis as being a plaque-associated pathological condition characterized, of course, by signs of inflammation of the soft tissues, bleeding and or suppuration together with a progressive bone loss. Again here, a clinical example where you see the probing is quite advanced, so deep pockets are detected around these implants. There is a sign of inflammation, typical, which is profuse bleeding, and this is confirmed in the X-ray, where we see that this implant is affected also by loss of supporting bone.
Removal of the biofilm is one of the key challenges in treating periimplantitis. At Straumann, we are aware of the importance of peri-implant health, and we have been scouting for innovations that could help clinicians treat periimplantitis. We found our answer: the Galvosurge dental implant cleaning system. Galvosurge completely removes the biofilm from the implant surface in just 2 minutes, setting ideal conditions for successful healing. In the next 10 minutes, the co-inventor of Galvosurge, Dr. Markus Schleff from Germany, will show you the scientific evidence and clinical possibilities with Galvosurge.
Periimplantitis is difficult to treat, you will agree to that. How can you clean an implant surface which is rough, which is microtextured? How can you achieve a result which approaches somehow to healing? What we can do today is reducing inflammation, right? And this is kind of frustrating for me as a clinician because, yeah, the success rate is low. So my way before Galvosurge was removing all the implants because my success rate was 100%, that periimplantitis was gone all the time. But this changed my behavior totally, and I'd like to share with you the background of the development of this story. What shall we do with an implant like that? How can we treat the microstructure? How can we treat the internal parts of the implant? Again, this was the way I treated the implants before. Then we had this idea. We started to develop a machine. We did an animal study, which was supported by Straumann, by the way. 2015, it was done. We did it in Brazil. And this is one of the typical results of this study, a complete reosseointegration. I never saw that before. Obviously, this technique succeeds in providing a surface which is at least close to the surface which the manufacturer supplied. That bone really can regrow on the implant. This was the first time I saw a healing of the defect. And the first idea was so new that we did it in a cave that nobody could see what we are doing. And the technology now is very simple. I explain with this little video how it works. We contact the implant with this spray head. This spray head conducts the electrolytic load. The electric load, there is an electrolyte, and this electrolyte passes the anode, which is positive. The implant is loaded negatively, and via this electrolyte, the current is transferred, and we have this process of electrolysis. How does it work exactly? Water splits by itself in hydrogen anions and cations. And the hydrogen cations, they penetrate the biofilm within milliseconds because the implant is loading negatively. And this is the difference to the current method. It doesn't work ablative from the outer side. It works from underneath, directly on the implant surface, not regarding how it is, on every metal implant surface. And then it grabs an electron, and then we have hydrogen. And this hydrogen bubbles, they lift off the biofilm. So it's also a mechanical cleaning. But it's a different mechanical cleaning because it works underneath of biofilm and lifts it off. And it really lifts it off completely, as I will show you in a while. This is a clinical video. You can see you can remove the restorative parts and clean also the inner side of the implants. This is for dentist. Failure is when the assistant uses the suction device and removes all the electrolyte, then of course it doesn't work. So the dentists need to be educated to use it in the right manner. But if the surgical site is really flooded by this electrolyte, then you will have a sterile surface after 2 minutes. In any case, as I will show you in a few seconds. Now I need to prove that what I claimed. I claimed removing of all the bacteria. Of course, proving starts with in vitro tests. These are implants placed in a mouth, protected by this plastic shield. And after a biofilm grew on that, after 2 weeks, we removed the implant, put it to a glass with electrolyte and cleaned this implant electrolytically. Different surfaces, different brands. This was is a typical situation before cleaning. This is after. We did not find a single bacteria, not a single bacteria in SCM after this cleaning process. Then we approached the members of the German Society of Implantology to send explanted implants in a salt solution, and those who did that in a fast manner could be used. 403 implants, different brands, different surfaces, different alloys could be tested. I picked out 2. This is a very smooth one, just a sandblasted surface. This is bone. Where bone is in contact to implant, no effect because the electrolyte was not in contact. So that just cleans the exposed metal where the electrolyte is in contact with. And this is the typical result from clinical implants, explanted, so not a single bacteria to be detected. And where bone was in contact to the screw, no effect. We can claim that in a lot of in vitro tests, the biofilm was completely removed, proven by SEM. Then, of course, we started to go in clinics. This was the device developed, and you see the electrolyte, you see the contact to the implant, which transfers the current. And this was the first clinical study for a CE mark. We had 24 patients, strict hygiene programs. We removed the restorative parts initially. I went the safe way and decided to go submerged. So we removed everything, waited for 2 weeks, then you see the granulation. Now augmentation is easier, as you can see. We had 2 groups, one with powder spray, one with Galvosurge. And because I knew that powder spray will not work, we added another Galvosurge cleaning after that. Then we augmented submerged healing, and after 6 months, second stage. What can you learn out of this study? If you compare those groups, you can assess, are there difference in the reduction of bacteria? Here you can compare a difference in cleaning by PCR testing. We did a PCR testing. And on the long term, you can see if additional mechanical cleaning is has additional advantage. To show you a clinical case, how this device works, we remove the restorative parts. This is 2 weeks later. Then we raise a standard flap, crestal approach, releasing incision if necessary, or just raising the papilla beside. Then we did some probing, of course, for the study on 6 points from the crest of the bone, then this electrolytic cleaning. If you see bubbles, then the process is working correctly. If you don't see bubbles, then something is wrong. Maybe the suction device removes all the electrolyte. And then we achieve this results. This is xenogenic and a mixture of allogenic material. And this is the healing after a week. And this is after 6 months. And this is the clinical result after 6 months. I don't talk about reossencration now, because I don't have histology at that time from a human being. Let's call it bone fill, right? I guess you will accept bone fill. This is a complete bone fill higher than the crest of the implant. I never saw that before. And this was the control group. First, powder spray cleaning, PCR test, then electrolytic cleaning, PCR test, and then we assess differences. On the long run, these were the results. No difference between those 2 groups. What does that mean? That means electrolytic cleaning alone is good enough to provide the surface we wished. So it's not necessary to use titanium brushes or whatever to do an additional mechanical cleaning. These are the clinical data after 18 months. Based on radiologic findings, you see a lot of, we over-augmented, so T1 directly after surgery is below the 0 point, but then you see the bone stayed quite stable. And these are the probing depth. Please look only at the mean. You see the major differences in probing depth. So we proved that we achieve really long-term stability. Now some cases. Again, very easy are those one-wall defects with crater-like defect. But is this really an easy case? If you probe on the buccal aspect, you are in the sinus. It was only attached a little bit on the lingual side. If I would use something and enter this bony defect and wobble around a little bit, then I would have the implants in my hand. This was the situation. Now the cleaning, the augmentation, this is bio-os and autogenous bone in this case, and PRF particles. This is the healing after 6 months. And what did we see? We saw more bone after 6 months, I guess because there was the Schneiderian membrane as a limiting border apically. I guess by the pressure something was pressed out. And when we raised the flap, then we didn't find the implant anymore because the bone overgrew the implant. So we had to grind away bone to find the implant again and to replace the old restoration. And now you see the big advantage of this technique. This saves also the restoration. If you remove it and decide to go for a submerged healing, then you can reuse the restoration. If you leave it on, so then it's easy anyway. So economically, it's a big advantage for the patient because you don't need to redo the whole restoration. This is a 9-month result, and this is a 33-month result now. So is it long-term yet? Of course, the first cases, we were very careful to follow them up. So really long-term cases, let me say I have 50. Finally, I treated now more than 400 cases.
Thank you for watching, and stay tuned for further microlearning series on the management of peri-implant diseases.